So it's okay now?
Yes, ma'am. Your screen is visible.
So good afternoon to all the participants and welcome to my session. So we are going to have today a talk on malignant wound. Okay. So I think almost 22 nurses have joined. You all must have come across malignant wounds. You must have seen cancer wounds in different shapes and at different places. Okay, with different sites. Okay. So you must be doing your own management also in your place. So every hospital has its own protocol also to do it. But we are going to talk about only about the palliative care, what we are doing. Okay. What is the setup, what we do in our OP or home care and everything. So simple to say, it's a primary or a secondary malignant growth in the skin, which is ulcerated and difficult to heal. Remember two things, it is ulcerated and difficult to heal. I think most of the patient percentage when we talk, it is not a healing ulcer, okay, malignant wound. Day by day, like a small pepper grain, it will grow like, I don't know how big it becomes also. Maybe just like a watermelon or a cauliflower, it becomes so big. Okay, so it is difficult to heal in while communicating to the family member day by day as you follow up. It is important that you come and explain to the family member about it, that it's not going to heal. We will be able to control only the problems in that, and day by day this will grow. Okay, this information is very important. So 5 to 10% of the patients with metastatic cancer will develop a malignant wound. Okay, about 5 to 10%. So most common sites where we see is one is breast, head and neck cancers, back, trunk, abdomen, groin and axilla, and the genital regions. Mostly, if the people from Northeast mean, they must have seen more of head and neck cancers. Okay. Now, breast cancers also become very common in that way. So the issues, you see this one. This patient had come to us with this wound kept open. So I would like you people to put in the chat box. You're seeing this wound. What all problems this patient will come across? Common problems. 1 or 2 answers, it will be good. It will be a little like the interactive also. What will be the problems the patient will be facing? What issues are there in this wound? Anyone? You can just put it in the chat box. Let it be wrong, no problem. This I would like to know what you know about it. Pain, very good. Angela has put pain. That's very good. So common pain. Breathing difficulty, some patients will have because if it is go inside. Yeah, very right. Anything else? Jayashree. Infection, very good. Tata Rajdevidas. Good. Infection could be the foul smell, very good. Angela has put again. Anything else? Dyspnea. Yeah, okay. Not on all the wounds won't have dyspnea, but specifically when it comes to the head and neck cancer, sometimes of course they will have dyspnea. That's why many times they go for a tracheostomy also. Okay, so we'll just see to what are the problems. So issues whenever there is a proliferatory primary or secondary malignant growth in the skin, it causes relative loss of vascularity. There will be necrosis, ulceration will be there. Very important is the cause is what? There will be infection by the anaerobic and aerobic bacteria. Okay, aerobic bacteria. So when it is an anaerobic bacteria, the foul smell increases. Okay, which can lead to many issues, as you people said, pain, infection, like these patients will have dyspnea, you said, foul smell will be there. That is very right. Okay, so the problems when we do, we can put it as physical, psychological, social, and spiritual. So you all have completed your introduction to palliative care sessions, communications, some other symptoms. So when you take a patient please focus on their physical, psychological, social, and spiritual. It's not only for a wound patient. I mean, a total, any patient comes to you in your hospital, just go through all these problems. Okay. Now, what are the physical problems and what all can cause pain in the wound? Can anyone tell me or put it in the chat box? What can be the cause? What can be the causes that will develop a pain for the patient? Cause of the pain in a wound. What all can cause pain in the wound? Physical problems will come back. Okay, I just want to know what will be the fever, discoloration of the wound, plus impaired circulation. Okay, impaired circulation can cause pain. Anything else? Anything you feel swelling can cause pain, right? Anything else? Infection can cause pain. Infection. I just want a specific answer. One more thing. These are okay. Edema. Okay, now I will tell. So we'll just come to the point now. Okay. Physical problems, as you said, pain is the pain can be of different, that will come back. Malodor, that is called foul smell, infection, bleeding, exudates, and infestation with maggots. That also can happen. So main as we take pain, malodor, bleeding, and maggots. Okay, these 4 things we have to remember. Okay. Now, what all can cause pain? So psychological will finish. Altered body image. Suppose there is a wound over here. My body image has changed, right? I cannot go out. I have to cover it up. Okay. So people, it is visible to the public. So that altered body image, my sexuality is affected. The fear of death will be there. How I will die, like this patient you have seen. How I will die, what will happen here, whether I will feel breathless. So many things can happen. Patient will become depressed and anxiety will increase. The anxiety of death, anxiety of the family, anxiety of this wound, anxiety of bleeding, lot of things are there. Okay. Shame also is there because still it is considered as a stigma. Cancer is a stigma in the society. Some people think that because you have done something wrong in your life, you have such a wound. Okay. And isolation. Isolation in the sense, patient may become self-isolated. If the patient finds that nobody is interacting with me, then why should I go out? So patient what does is he keeps his door closed. He will be inside a room. Okay. So we have to prevent self-isolation, family isolation, and social isolation. This thing is very important. Otherwise, the patient will slowly draw into depression. Social problem, that's what I said, family isolation, social isolation, self-isolation. Okay. Stigma is still the effects on family. That is it. Okay. Family is also affected due to this symptom, due to the smell of the wound. They won't be able to eat food. That is that they are not able to go out, leaving the patient alone. Okay. So their social interaction also reduces. And of course, there used to be sexual relationship and marital disharmony. A lot of religious spiritual problems arises. They think, why this happened to me? What wrong I have done in my life? Okay. Or maybe they feel guilty that they have done something wrong in their life. That is why they are suffering. God has punished them. Okay. And fearing of that impending death. So a lot of problems come spiritually and religious. They start questioning also, why, what is the meaning of my life now? What is the purpose of my life now? So let us come to the principles of management. It's a palliation of the symptoms. Okay, we are doing just reducing the symptoms. We are not going to cure the disease. Okay, it's a holistic care. And of course, we need to empower the patient and family in wound care. That is very important. How to take care of a patient, how to take care of a wound, how to dress it, how to clean it. These things we have to teach the family member. Why? Once they go back, the dressing, everything, these people have to do it, right? Nobody's going to help them. So we need to teach them and make it follow up. So surgery used occasionally to reduce the tumor mass, but not always possible due to bleeding and infection. Okay. When we talk about chemotherapy, again, to decrease the tumor mass, we can put a chemotherapy, but it depends on tumor response also. Many times it won't respond. Radiotherapy, usually to reduce the size of the mass, controlling exudate, bleeding, and pain. That is another thing. Now, assessment, what we have to do is the wound location we have to assess, how the wound appears, the surrounding skin of the wound, and of course, if there is any potential for any complications. This is very important. So when we set about the wound location, where it is located, if it locates somewhere here and all, sometimes it's very difficult to even for dressing. Okay, I've seen a patient wound was over here, so his eyes were swollen, ears were swollen, everything has turned upside down. It was a lot of problem was there. And how the wound appears. Okay, as I said, it appears like a cauliflower, or it, what is it? It smells, everything, necrosed or what. These things we have to see. And the surrounding skin. Suppose the wound is here, the surrounding skin is very important. Now, just now I saw a patient over here. The surrounding skin was very fragile. Okay, because it's going to open up. So when we put a micropore and all, we have to be very careful while removing. Okay, so that is one thing. Okay, so now we'll come to this one, steps of wound dressing. Okay, the first and foremost thing I asked you a question, what can causes pain in a patient? What are the causes of pain? Otherwise, what can cause pain in a wound in a patient? Okay, first and foremost cause is what? The first and foremost cause is what we cause for the patient. We just, well, now the patient who had come, the patient was very scared. Why? She was not allowing to the dressing. Because somewhere they have done the dressing. Okay. So what they did is they have pulled this one. They tried to soak it, but it didn't come. So they have taken it, caused pain for the patient. So the patient said not to do it. We'll go home. Okay, so we cause sometimes pain to the patient without soaking. We will remove it. Okay, sometimes we will soak it, and when it comes to the nearby, it will be adherent. We'll try to remove it, and that will cause pain for the patient. So what happens next time when the patient comes? Patient say, "No need of doing dressing. I'll do at home." They will neglect it. Okay, so remember, soak nicely, very well, and then only remove it. As I say, if I put my hand to remove it, the gloved hand to remove it, it should just come to my hand. It's not that I'm pulling. Clear? And when you do a dressing, you should have empathy and a loving care, because already the patient is running through a difficult situation, difficult days. So we have to see that our approach, our attitude, everything is good towards the patient and the family. Provide a thorough bath before dressing if there is foul smell, malodor. Okay, especially in India, in this one, many patients coming from the tribal area, or some patients must have not done dressing. When they come to them, there will be a lot of smell will be there. Okay, foul smell will be there. So in some setup where in the hospitals, in the hospice or in a palliative care, there is a place for the patient to give a bath. So give a good bath. So what happens? Everything washes off. This wound, the dressing also will become lube. This one. Mm, it will be soaked well. Okay, so we can remove it. After giving a wash, then we can start doing the dressing. So syringing with normal saline to remove the slough, or the lot of pockets will be there in the wound. So take a syringe, take saline and nicely syringe it. And sometimes there is little, because slough we are not supposed to cut it and remove, because it will start bleeding. Okay, so what we have to do, just syringe it like this so that the slough will slowly remove. And always put a non-adhesive gauze to remove the exudates. Okay, absorbable one. Okay, so usually in our hospitals we have only gauze pads. Okay, you can put gauze pads, no problem. You do one thing, we use usually Metrogyl powder. Metrogyl tablets are powdered nicely. We make it a paste with the silocaine jelly. Otherwise, you can with the Vaseline gauze also you can use. We can use a liquid paraffin gauze also you can use, so that it won't stick to the wound. Okay, so apply the Metrogyl powder, because Metrogyl is very good to reduce the smell, especially it acts on the anaerobic bacteria. Okay. And top of that, you can put a liquid paraffin gauze also. Okay. Then give a good dressing. Okay. While giving it this as far as possible, these places you can put the bandage, normal our cotton bandage, you can do it. But suppose it's on the face and all, sometimes it's difficult. Put a small piece of this one, micropore only, which can be easily removable. That is one thing. And the second thing is when you can ask the patient to put a mask also on top of that so that it is in place. Clear? So that's what I said. And attention to always to the wound margin and healthy tissue. I have come across this patient, just 14 to 15 years, you had a very big wound on head and neck cancer. Very big wound, and he never allowed them to do the dressing because he said if you people do dressing, it will start bleeding because he had that experience before. And being a very intelligent child, he knows if bleeding starts, it won't stop and he will die. Okay. And when I saw it was just open, it was so big, it was kept open. I just approached him. I came to know this. I approached him. I bent on him. I just asked, can we just cover this? I didn't say dressing. I said, can we just cover this? Okay. So first he said no. Then I asked why. He said, if you cover, it will stick onto my body. Then when you take, it will start bleeding, he said. Okay. So I said, I'm not going to do a dressing for you. Okay, it is so visible to everyone. I will just cover it. I don't know, maybe by my talk, he must have felt confident about that. Then, with a smile, he said, okay. What I did was, his father was having one towel on his, this one. I just took the towel, made it in a triangle shape, and I just tied like this. Okay, so what happened? This wound was covered. Okay, and I can see he was just smiling. Of course, he was then admitted to our palliative center. And after 3 days, when I went and visited him, nicely dressing has been put. And you know what he said? He said, here there is no bleeding and all. They are doing it very well, it seemed. Okay. But of course, towards the end, he had a massive bleeding and he died. Okay. But he was not knowing during that time. He never knew that he was bleeding also. Step this one. So first and foremost thing is minimizing pain. So first thing is always soak the previous dressing and then only remove it. That's the one thing which causes pain. The second pain is a deep pain, stabbing or aching pain. Okay, where the patient has to continue with the analgesics. Whatever the patient is taking, ask the patient to take it when the right time. And suppose the patient comes to you and still complaining of pain before dressing, just give the painkiller first. Let the patient take the medication. After 45 to 1 hour, you can start doing the dressing. Superficial pain where the patient will stay, stinking pain, prickling pain, burning pain. Okay. In that cases, you can use xylocaine, lidocaine solutions or jelly out. Sensocaine is also very good. Okay. Just dilute it. Otherwise, soak it nicely in a gauze and just keep it on the wound. Okay. It reduces the pain. 10 minutes it will take, it will reduce the pain. Otherwise, you can just take in a syringe without a needle. Okay. Take it in a syringe and then spray it on the wound. It reduces the pain. And of course, for incidental pain, in some places we do sublingual ketamine. Incidental pain is like whenever I move, I get pain. Suppose I go to the washroom, I get pain. When I swallow, I get pain. So for that, we can incidental one. Now, malodor, as I said, daily cleaning and dressing is very important. Okay, so you can ask the patient's family to give him a thorough password, all the smell which is there, that is washed away. Then they can use saline cleaning. After saline cleaning, apply local metronidazole. Okay, metronidazole tablet can be crushed and powdered and put. Okay. Irrigation with injection metrogel is also good when there is a malodor. Malodor is severe malodor is the use metrogel solution to irrigate it nicely. Systemic antibiotics can be started if it is very severe malodor. And of course, according to the oozing, frequent changing of the dressing has to be done. It's not the morning I have put a dressing and you are continuing it with next day. No. If that's wet, soaked, remove the dressing. Managing infection, I already spoke to you. I told you daily dressing with metrogen. Of course, in palliative care, we don't do any slough cutting or hydrogen peroxide or betadine. Okay. Simple saline dressing is the best thing to do. Apply metrogen if there is smell. Now, managing bleeding is very important. Here it comes. At times, if you don't soak it properly, don't soak the previous dressing properly, and you try to remove it, the patient will start bleeding. Okay. Otherwise, also head and neck cancers, we can't say once the wound starts infiltrating the main vessel, our carotid, it will blow up. Okay. So whenever there is small bleeding, apply a pressure with a pad, and if we can use even sucralfate tab sucralfate, you can powder it and you can use. You can just put it on the spot, give a pressure. Systemic ethamsalate can be given. Okay, and of course, palliative radiotherapy also can be given. Okay, but again, when there is a massive bleeding, at times we are not able to stop it. Okay, it becomes difficult. Okay, so I have seen patients who had a very massive bleeding, sudden blowout, and the patient just goes like this. Okay, the main thing in the bleeding is whenever a head and neck and cancer come patients, please do inform them, otherwise sit and communicate to them the importance of that bleeding when it happens. If it is a massive bleeding, not to, because many times what happens, they just rush the patient to the hospital. On the way, the patient must have died of bleeding. Then it becomes very difficult for the hospital people also, because it is like a broad dead and they have to do their own rules. Many rules are there. So filling the papers and all takes a lot of time. So educating, empowering the family member about the bleeding, about the maggots, and these things are very important. You see, it's bleeding here. It's bleeding. Okay. Maggots in the wound. Physical removal we can do. First is prevention. It means 24 hours the the wound should be covered properly. Okay, daily cleaning and dressing, and it should be covered. And in places where there are flies and all, they can use the mosquito nets. Otherwise, turpentine oil is available. Just dilute 1:1. You can dilute the turpentine oil. Take it in a syringe and just spray on the wound. In the wound, you have to, not outside the wound. Okay, where the pockets are there, just spray it. Cover it with the gauze pad. Wait for 10 minutes. This will slowly start coming like this. Okay, that is one thing. The second thing what you can do is soak the gauze nicely in turpentine oil and you just cover in cape. So it suffocates the area. The maggots will start coming out. So maggots has to be removed with the forceps. Thumb forceps is all what we say, dissecting forceps is there. That is good, but not the tooth one. You can just remove it, put it in hot water. So keep the hot water ready. So just pick it up, pick and put it up. Okay. And then clean everything with the saline. Clean now with normal saline. Okay. Then you can put a pad, send the patient again. So like the 3 to 4 days, you have to continue doing with turpentine. And then send the patient and tell the patient 24 hours this has to be covered. Now we have removed all the maggots. But now if you don't take care, again the patient will go for maggots. Okay. So you see this patient, how can you see? And one more thing, can you see it is a little bit dark over here? Why, when the maggots get a direct light, it just withdraws inside. So never ever put direct light when the wound is that you have to remove the maggots. It should be from the opposite side. And as far as possible, if you make it little dark inside your procedure room, then it is easy to remove. So it is put in a boiling water or in a turpentine oil. You see, this is only for one patient while I'm talking. Now, this patient I have seen directly, this patient, so I know very well, almost about 55 plus or 60 something patient had come. This is a CA buccal mucosa it was. You can see here how it is. Even inside also, everything is gone. Wrapped in a bed sheet, they took the patient. When the patient came to us, I was shocked to see such a big, you can see, so big maggots were there, which were falling on the floor. When I asked the family member, 50 people are there in a family. They are a joint family. Nobody cared, including the wife. They all neglected this patient. When I asked them, they said, yesterday only maggots came. I said, it's not yesterday. It was there for a long time. And you people never noticed it. And the patient was screaming with pain. Okay, actually, pain, not only pain, it must be, it's you see how it is. Okay, might be crawling and must be feeling something. Okay, so immediately what we did was, of course, we removed his dress under. Can you see this dress? Everything soaked. We removed his dress. What we did was we gave this morphine for pain relief. Okay, then we had to take turpentine diluted with the saline, and we just soaked and kept all these portions. Maggots were just running like anything. Okay, you see cluster. It is just like formed a ball like here. Okay, we removed the first day, but the patient was in a terminal stage. Second day in the evening, by the patient passed, died. You see this wound again. How to clean this wound, that is very important. Okay, through this you can, this one, syringing is best done over here. Keep a kidney tray over here. So you syringing, it will come out because the patient is not able to open her mouth fully. It will be difficult. So from here only you can clean. And after cleaning, you can do one thing. Okay, just put a pad over here with Metrogyl itself. Okay. And suppose this patient wants to eat, otherwise drink, don't end up putting a Riles tube. Okay. Ask the patient to eat by mouth. She can have a straw and drink juice and everything. After that, again, clean this area, then put another dressing. Okay, and you see this one. This was a very difficult situation. Already a small fistula has been formed over here, and somewhere the other side also there was a fistula. This all due to sometimes negligence also it happens. So prevention of maggots, as I said, I've told you already how to prevent how to prevent the maggots. Daily dressing has to be done. Keep the wound covered. Use mosquito net. Okay. And of course, apply plain turpentine oil with a syringe. Otherwise, you can see that it's better diluted. So even after dilute, sometimes we have to be very careful. It should not spill on good skin. One patient had come with cervical cancer. Her whole that vaginal pubical area, pubis, was burnt like anything because they have used turpentine. They were not knowing how to use it. They just poured the turpentine and it burnt her this one pubis perineal area. So we have to be very careful with this. So training for the carers. Just 1 second. ഞാനൊരു ക്ലാസ് എടുത്തുകൊണ്ടിരിക്കുക കഴിഞ്ഞ ഉടനെ വിളിക്കാം. Wound care in advanced cancer is very important. Okay, so we have to empower the family members to take care of the patient and the wound. So please do explain to them, if you don't take care of a wound, what is going to happen. Pain will be the maggots can come, smell will be the exudates will be the family members won't be able to eat. The smell will go all over the house. So tell them, if you take care of this patient, it's not going to heal, but you can take care so that these problems will be reduced. So training of the carers, also find out what is their knowledge, their attitude, and whether they can practice it. And we demonstrate it. You can practically demonstrate it and ask them to show us how they are going to do the wound care. That is important thing. Regular follow-up is another thing. If the patient could come to your place, well and good. Suppose the patient is not able to come to your place, okay, we can make a follow-up through this one, home care. Even over the phone also, there is video call. They can take a picture of the wound and they can send it also. Some patients, family, they do it. Okay. Realistic goals of care, that is improving the quality of the care only we can do. Palliation of the symptoms. We cannot cure it. And of course, preparation of normal saline and sterilization of dressing materials. Okay. Now, how to prepare normal saline? You know, one normal saline cost, it's good cost it is. Okay, so better what we do, 1 liter of water, 2 teaspoons of salt, put it, boil it, just boil it, cool it, this can be used. Not to be stingy. Pinch of salt in water. No. 1 liter. Such wounds now need 1 liter of water. And that same water can be, saline you make and keep, they can have a mouthwash you can give. This can be used. Only that it can be kept just for 3 days, not more than that. Okay. If you daily do it, well and good. Daily, if you could make normal saline, well and good. I hope this is clear. And sterilization of dressing materials. Of course, if you get the gauze and all good, but suppose patients are in the village, not affordable, what they can do is old cotton clothes like lungi, shawl, sari, everything is they can just wash it properly with soap and water, dry it, cut it into small pieces according to the size of the wound. Okay. And that can be sterilized. How sterilized? We say usually, you know that we make idli. One big vessel. Okay. Keep water down. On top of that, you can keep another one plate or a vessel which has got some holes and all. Okay. In that, you can keep all these materials, what you have cut. Close it and keep boiling. Once it comes on the boiling point, okay, just remove the lid, put off the stove. Okay, put off the gas. Then after that, what you can do is let it get little dry. Shift all these things into a clean container. Washed, clean container. You can wash it with in hot water also. It should be dry. Just shift it. And these materials can be used for the patient. Only thing is, you need to teach them about hand washing. Of course, COVID has taught everyone how to do hand washing. In fact, we nurses may forget. So hand washing is very important. Tell them not to put their hand inside this a container to remove the gauze pieces. Tell them if they want to remove also, they can remove with 2 fingers only. Otherwise, they can use this tongs. Okay, when we make chapati or some fry or something to remove, tongs are available. The tongs can be used only exclusive for this patient. So this is how to do the dressing materials. It can be kept for 2 to 3 days. Third day again, we have to sterilize it. Saline, I told you. Best way is to prepare daily for use. I just told you if you can keep 2 days, 3 days, not more than that. Okay. Daily, it's done, it's well and good. So cotton clothes, I told about this thing also. Every third day you have to sterilize the material. You can use tongs, chopsticks you can use. 2 spoons, the spatula of the 2 spoons also you can use. So the ideal aim is to complete healing, but which cannot happen in a malignant wound. So a lot of problem is then we have to minimize their pain, infection, bleeding, odor, maggots. These things only we can manage. And of course, the psychological trauma. Shiva, it is 40 minutes, right?
Yes, ma'am.
Okay, I'll just complete it. Okay. And the primary, our aim should be only comfort first and try to improve the quality of their life. So there is one more thing. Once you have made the assessment of the wound, okay, you can think what type of dressing you are going to use for the patient. Okay. And in palliative care, many times, if it is not affordable, we are using simple this one now, what to say, gauze pads and gauze only we are using. No, we are not using cotton. Okay. And but of course, the affordable people and big hospitals, corporate hospitals, they have a many number of dressings they have, different dressings they have. They can use it. But what about a patient who goes back to the village where it is not accessible or it is not available there? So it becomes difficult. So teach them which is affordable, which is at hand, easily to get it. Okay. And so there are no rights and wrongs. Like this only, if you do, it will become okay. Like this only we do, it will become okay. Some things are not said. At times, sometimes we have to cross our fingers also. Okay. Commercially available products are available. If it is affordable, they can buy. Okay. So in a malignant wound, we have to think about the underlying problem. Any comorbid conditions are there, local wound management and symptom management. So suppose it's a cancer patient advanced with the diabetic hypertension, any of the wound is not going to heal, but the patient is going to have more other problems. Okay, so these things we have to keep in mind when we are dealing with wounds. Okay, so clinically assessment should be done, where the site, the size, and everything. If it is going to press if there is any bleeding, this thing can become documented properly, and evaluation should be done properly. Okay. Particularly important in palliative wound management where the evidence is not well established. Okay. Nowadays, we say everything should be evidence-based, but at times it's very difficult also. Okay. So our focus should also include the level of understanding about the wound for the patient. As I said, they may think it will heal, but it's not going to heal. So we need to try to make them understand, otherwise find out whether they know about it. If not, then we need to do a good communication with them. Try to improve their quality of life. Their social and financial concerns has to be addressed, like emotional, cognitive, behavior, everything should be addressed. And of course, this problem, this wound problem, and the problem in the wound, how it affects his family, him and the patient, and on the family. That is important. So the goals of care always are the aims for the person care. We have to focus on the patient's care. And the goals of care will change maybe within one day also. Sometimes yesterday must have done a dressing in a very bad wound. Next day when you come, the condition of the patient has deteriorated. So the goals of care has to be every now and then we have to assess it, and it keeps on changing. And the goals of care and intervention are for the maximal symptom control. We do the symptom control, maintain the function, whether it is going to cure or not, that is not our this one. So 2-3 things, I will just finish it off. Where the area, that area of the wound, that is important, and what is the burden and what is the benefit. You will be still learning about ethical issues, means in that we say that wound, the goal of our this one should be whatever we are doing, it should not become a burden to the patient. That's what I told you. Commercially things we may not be able to buy, but local things, whatever is available, we can do. So don't burden them. Okay. And disease modifying treatment will be stopped. An appropriate treatment decision making should be taken. The plan should be there. What dressings with that plan should be there. So manage the problem, pain and other symptoms, psychological symptoms for the patients. Okay. And non-physical symptom control also we have to educate and again plan it. Communication is very important. The progression of the wound has to be told to them, whether they know it, how they have taken it into their this one, that we have to talk to them. Okay. And what do they understand about this wound? That also we need to find. So good communication has to be done, and the communication has to be completed also. So we need a plan for that. Decision, who makes the decision? Suppose like the patient suddenly there is a blowout, bleeding starts. Okay, maybe a person who is in the house knows very well, he will tell nothing to be done, just put the patient, we will cover. So when we say bleeding is there, cover it with this a dark colored clothes, that is masking the bleeding. Okay, dark colored clothes, be with the patient, make him calm, and these things are very important. It's not that rushing the patient to the hospital. Okay, so who is the decision maker? If they are having something, they can do it. Who will take the decision? We can talk to them about this, taking appropriate decision also. Okay, so we have to plan these things. These all are the components of the goals. And practical goals is very important. Is it whether practically is it good to shift the patient, or we can take care of the patient at home itself? When some emergency comes, we have to think about that, because if the patient is in his end of life care, what is the point of shifting the patient to the hospital? So the issues that comes is place of care, where the patient can be cared, at home, hospice, or in the hospital. Okay. And another thing, loss of care and travel also. Suppose the patient is in the village, you won't be able to ship the patient to the hospital. It becomes difficult. So if right from beginning, if we talk to the patient and the family, and we respect their wishes, what they want, let us go in that path. Okay, so we need to have an open communication about all these things. What are the emergencies that will come? Most of the time, emergency is the bleeding and how it can be handled. Okay, that is very important. And the anticipatory goals. So, it's end of life care, what we can do. So, anticipatory goal is very important. Finish. Okay. So, with this, this all I have covered. Something I just put it.
Thank you, ma'am, for the wonderful presentation. Anybody have any doubts? Anybody?
Yeah, do you have any questions?
You can ask through chat box also.
If you don't have any questions, we will ask questions.
How turpentine oil is diluted? I told you with normal saline. Simple.
Yeah.
Okay, you can dilute it with normal saline. 1:1 is enough.
Yeah. Better you can soak normal saline
Yes.
within the gauze piece and keep close to the wound so that the maggots will come out.
Come out.
Yeah.
Cover it. We say the darkness should be there.
Yeah,
Nice.
yeah. So
Cover
that
it,
time,
it
yeah,
will suffocate and it will come out.
yeah.
That's what I told you. No direct light. It will go inside.
And also, if you pour directly into the wound, that will again cause irritation. So better you have to dilute it and apply if you want to apply directly. But so what we do here is we usually soak the turpentine oil with the gauze piece and keep close to the wound so that
Yes. That
maggots
is
will
the
come out.
best thing. Yeah, that is the best thing. Mostly people do it. They soak it nicely with the turpentine plus saline, this one, and they keep it.
Okay, yeah.
Other than cancer, chronic wound, same steps to be followed. Yeah, you can start like the patients who are coming to palliative care, like diabetic wound, pressure ulcers, and all. We do the same thing, right, Shiba?
Yes, yes. The same thing. The thing is, one of the major complications of
You
the
have to keep in
chronic
mind
wound
that.
is marginal ulcer.
Yeah, that we
Sometimes
have to keep in mind.
cancer cells can develop from the chronic wounds.
Yeah,
So
chronic.
the management will be the same for these kind of wounds also.
And sometimes, of course, from the hospital and all patient comes, they must have written some antibiotic to use for that. That can be followed. There is nothing. But once the patient is completely in a palliative care, what is affordable, you can use it.
Yeah. So the thing is, if for the chronic wound, we can, if there is a slough there, you can do the slough cutting.
Cutting
Okay,
also,
you can,
pressure
yeah.
ulcer, like
But
pressure ulcer.
the cancer wound is not possible.
No,
You
that's what I'm
should
saying.
not cut the slough. So that proliferative cells will be there all the time. So don't attend the slough cutting for the fungating wound. That again cause bleeding. So
I told you about this one, that question. That is where it went. Yeah, for a bleeding, when you are dressing if you find bleeding, suppose there will be spot bleeding. If there is a spot bleeding, if you have sucral fate, if not, ethamslate itself, crush it, remove the coating, and just put it on the spot and give a pressure. Okay, that is very important. So why usually while doing the dressing, it may bleed. Why, sometimes you must have not done it properly. That's what we say. Never scrub the wound. Okay, just after putting saline and all cleaning, just mop it only, pat it just like this. It's not like if you scrub it, it will bleed. Even if you do the if you try to remove the dressing without soaking properly, it will bleed. And of course, head and neck cancers here. You see, this is like a main way. This one artery is there. It will start bleeding means you cannot control it. Okay. And if you find out every now and this bleeding is there, of course, doctors do you put the patient with an ethamsalate or some medications they will start off for the patient. And covering the wound, if massive bleeding, please do mask the bleeding with dark colored clothes. That you have to inform the family, not to cover with white cloth. Okay, that is it.
So that is true. That is you have to prepare the family. That is very, very important. If there is a head and neck cancers, one of the major complication is bleeding. So maybe because of that bleeding, that patients might be dead. So that you have to talk to them and prepare them. If there is accidental hemorrhage there, they have to take a dark color cloth and wipe up the blood. So that we can avoid anxiety, panic attack, that kind of. Others will develop anxious. No other relatives will be there.
Able to manage it.
Yeah, so they will not be. So that one thing, and the one more thing, ma'am has telling about the dressing removal. Usually the dressings are adherents to the wound. Before soaking the dressing, just try to remove it. Definitely that can cause pain and bleeding. So always try to prevent bleeding. So you have to soak the old dressing with normal saline or normal water and then try
That's
to.
what I told you. You can give a bath also. So like in home care and all, what instruction the patient will be given, you give a bath, we will be coming and we will do the dressing because we need to see, we'll give a thorough bath. So thorough bath, lot of water will go and the smell also will wash out. Patient also will be clean.
Yes,
Overall,
yes.
patient also will be clean. That we can do.
Yeah, that all necrotic tissues will fall on because these type of wounds are fragile. So if you apply more pressure, it will start bleeding. So if they are able to take bath, you have to advise them to take bath before dressing. So and the another important thing, so there are a lot of necrotic tissue coming out because of that malodor. So it will be affecting the patient and as well as the family. So try to avoid that bad smell. So the metronidazole is the good drug for controlling anaerobic bacterial infection. So you have to advise them to apply metronidazole tablet, or they can irrigate the wound with the metronidazole injection. And nebulization also. If there is a foul smell there, you can use, not through mouth. You have to give nebulization into the wound.
Yeah, that's what I tell. Keep it near. They say even if the patient is having a cea buccal mucosa and all, there is lot of smell. Just instead of what is that salbutamol, you put it metrozil, and you can just that fumes has to go near the wound, so it reduces the smell. Yeah,
and the charcoal. Charcoal is the best agent for controlling bad smell. So the
second layer of the dressing should be charcoal.
Charcoal, yeah.
Activated charcoal if you get, well and good. Okay. Otherwise, you can do one more thing. Keep in the room of the patient charcoal, fill some buckets or something so that it will absorb the smell right from in the air itself. Okay. Now somebody asked, maggots compulsory 24 hours wound has to be closed. Yes, dear. 24 hours cancer wound has to be covered and kept because it attracts the flies and the patient will develop maggots. Patient won't be able to see where the flies are coming. It's very difficult. Okay. They have to cover it nice. That's what I told you. Flies are there more means put a mosquito net. Any of the patient is not moving out means put a mosquito net, let the patient be, but it should be covered for 24 hours. Otherwise, they will develop maggots and without our knowledge, after some time they will come. Not even that. If the patient says everything was fine, suddenly the smell has increased. Just start thinking, maybe maggots is there. And if you put little bit of turpentine in the pockets and see small pin-like, you say a pinworm. I have seen just like pinworm, just coming out like anything. Okay, so 24 hours, it should be covered and daily dressing is important. These things you have to tell the family member. That is very important.
Yeah, so that is one of the important points you have to, but the patient and caregivers doesn't know maggots are come from flies. We all know that maggots are come from flies. So as ma'am said, these wounds are attracted. The infected wounds are attracted with house flies. So when they touch the wound, they may lay eggs. Within 8 to 12 hours, come out of maggots. So you have to tell them the importance of covering up the wound. And another important thing, while we assess the wound, so if possible, you have to take an individual assessment. But in front of because in front of the relatives, they may hide the truth. Always they will hide the truth. Sometimes some misconception will be there. They will be thinking like this disease will be spreading to me also. They will not allow to enter into the dining hall or kitchen or anything. They have to keep the patient all the time in the room. So that will be affecting the patient emotionally, socially, and all. So this we all know that what is total pain: physical pain, social pain, emotional pain, and spiritual pain. No, so if you do the individual assessment, definitely they will tell the truth. Then based on that, you can manage the patient. So if you don't have any questions, we can move on to the case presentation. Akshita will be presenting a patient story. Akshita, are you there?
Yes, ma'am.
Yeah.
Good afternoon, ma'am. Good afternoon, everyone. Myself, Akshata Shedesai. I'm a staff nurse and working at the Primary Health Center, Bali, Goa. And today I'm going to present a case on wound management too, that is on fungating ulcer. Patient details: 50 years female, diagnosis, known case of DM with cancer of left breast on chemotherapy and locally advanced breast cancer, left breast, also proliferative growth present. Presenting complaints: generalized weakness, difficulty sleeping, constipation, high blood sugar levels, and delay in wound healing. History of illness: a large ill-defined ulceroproliferative mass is noted in the left breast, measuring 2.5 by 7.9 by 5.4 centimeter in size anteriorly. It is seen to infiltrate into nipple areolar complex and skin with overlying ulcerations. Posteriorly, it is seen to infiltrate the pectoralis muscle on the left side. However, no obvious erosions of underlying ribs noted. On examination, pulse was 80 beats per minute, temperature was afebrile, BP 120 by 70, respiratory system clear, central nervous system, patient was conscious and oriented to time, place, and person. Wound was not infected and no foul smell. Wound was healthy and patient appears active. Treatment and significant investigation: serum urea 10.70 mg per dl, serum creatinine 0.63, serum sodium 140, serum potassium 3.7, serum chloride 104, and LFTs were serum total bilirubin 0.60, serum direct bilirubin 0.20, serum total protein 7.8, hemoglobin was 12.3 gram%, total WBC count 3,950 million, and RBC count was 4.30 million. Psychosocial aspects: she is living with a husband and two children, one boy and one girl child. Husband is the breadwinner of the family. Both the children are studying in college. She is housewife and husband is the primary caregiver. She has Pakka house. Her husband is doing private job in the company. No history of cancer in the family. No other significant history. Then medications: wound care dressing with betadine on alternate days, injection insulin, human ectrapid, that is TDS, and and 2 at 10 p.m. at night daily. Then tablet metformin 500 mg OD, tablet dapagliflozin 10 mg OD, tablet tramadol 50 mg BD, tablet Rentec 150 mg BD, syrup cremafin at night, and capsule D360K OD. Main concern: maintaining blood sugar levels, disturb sleep, constipation, and preventing infection and promoting wound healing. Summary: a 50-year-old lady with known case of diabetes mellitus plus cancer of left breast on chemotherapy and case of locally advanced breast cancer on left breast, ulcero-proliferative growth present. Patient received 4 cycles of epirubicin 140 mg plus cyclophosphamide 850 mg plus 2 cycles of paclitaxel 240 mg and due for 2 more cycles of paclitaxel 240 mg. Discussion points: do we need to provide palliative care for this patient? How can we prevent constipation? What are the problems faced by this patient? How can we prevent infection and promote wound healing? And how can we control her blood sugar levels? Thank you.
Thank you, Akshata, for the wonderful patient story presentation. I
Thank you,
hope
ma'am.
this presentation is clear to everyone. We can move on to the discussion points. So we would like to hear from you all. Now you all listen the theoretical topic. You all understand well. Now you all tell us, do we provide palliative care for this patient?
Can they unmute and talk?
Yes, yes.
So you all
Please.
can unmute and you can say. First one is, do we need to provide palliative care for this patient and why? Anything in the...
Please unmute. Please unmute. We all
Unmute,
nurses.
you put in the chat box also, no problem. Unmute and talk. Gautami, Jayasri, Lipi Biswas, Martina.
Yeah.
You all
Lipi,
can talk.
yeah, Lipi Vishwas. Please tell, do we provide palliative care for this patient and why?
Foreigners எல்லாம் இருந்தாங்க இதுல. ஒரு ஃபிஷர் இருக்குது. ஒரு is patient bedridden? No,
No,
patient
patient
is
was
not
active.
bedridden.
Lipi Vishwas, please unmute yourself and talk.
Rita Dias. ஓடிட்டா ஈவ்லின் தானே கார்டோசோ ரொம்ப பேர் இருந்தாங்க அது ஒரு ஃபாரினர் வந்தாங்க அதான்
Yes, we need palliative care for this patient.
Okay, why?
Acha, yes, for the wound care they are saying.
Oh, we need palliative care because we can provide, because he can't do the dressing by himself. We can give him advice and help him to do the dressing also. Or teach their members, also family members, so that they can also do properly.
Okay.
And
Yeah, madam.
yeah, and this patient is for a palliative care because day by day his wound is increasing. You have a lot of problems. They don't know how to take care of a wound. Okay, so we need to teach them also, and a lot of psychosocial problems will also be there for this patient. Okay, so this patient is actually a selected patient for elective patient for our palliative care. Okay, now how can we prevent constipation?
Modification diet,
Now modification in diet, good.
and sometimes we can ask how they are moving, like movement. If they do not have movement, so they must be there's a reason to become constipated, and we also asked how many times he go washroom or not he pass stool. Then we can suggest like laxative or other medications.
Medications, yeah. See here the patient is already in serum cremaphene. I would like to ask Akshata. Akshata,
Yes, ma'am.
how many days he is constipated?
Last 5 days, ma'am.
So last page. So you was he taking this clemafin properly?
Yes, ma'am. At night she was taking.
At night he was taking. Actually, she
Yeah.
was taking. Okay. So maybe with the sometimes with the laxative, the patient may not pass. Otherwise, the fluid intake is less. Patient is not eating properly. This also can happen. But 5 days means the patient is having really problem. So in that case, what we will do? It's already 5 days. Clemafin is being taken also. Now the
Yeah.
next, what is the step?
High fiber diet.
Yeah, no, that everything the patient has done, but still the patient has not passed and it's already, yeah. Purva has written.
Laxative.
Next is enema. Okay. So of
Enema.
course, yeah, Pratishta Nayak also said, but in palliative care, giving enema is a little different also. Okay. So maybe in the bedridden this one, when they are taking, they will tell you. So it's a little bit, but very right. We have to give an enema to the patient. That is very right.
Can we give the suppositories, glycerin suppositories to the patient?
See, 5 days it is. What is the use of giving a suppository? Already the patient will be discomfort with that. The patient may have colicky pain. Patient may not eat just because of constipation. So, okay, after being the patient already in a laxate, especially clemafin. Clemafin usually softens the motion. Okay. And even after that, the patient has not passed while correct the patient is taking, they are taking also. Now the next step is go for an enema. So in palliative care, we do a perectal examination. Hard stool is that we remove the hard stool, then give an enema. We say high up enema. Okay.
Okay.
And one more thing, this patient is on tramadol. So that drug can cause, one of the side effect of that drug is constipation. So you have to add some stimulant laxatives also.
Yeah, it'll be
So
supportive.
here, only the stool softener is there. So you have to add a stimulant laxative like bisacodyl or sodium picosulfate, something like that. So that the patients will, we can get constipation relief. So we can prevent constipation, no? And also, as ma'am said, you have to do the PRE and find out the fecal matters. And if there is a hard stool there, then like you can do the digital manual evacuation, and then you can give an enema. Okay, so based on the PRE findings, you can do it.
So what is the next question? Any idea?
Next question. Sorry.
What are the problems faced by this patient? Yeah, one we said about constipation. Okay. Before this one, I would like to, that one, concerns were there.
Yeah, concerns. Yeah,
Concerns
one
are
moment. This is the concern.
blood sugar levels. Yeah, blood sugar levels patient is in. Then, of course, you people said diet control has to be there. Everything we have to do. Disturbed sleep and constipation, we said. Disturbed sleep, preventing infection and promoting wound healing. These are the two things we. Now, disturbed sleep could be for why?
Maybe constipation is the reason.
Yeah, can be. Then?
Maybe he is tensed about his disease.
Stress, pain.
Yes.
Yeah, many have answered. Yeah. Due to stress, the patient will be disturbed. Due to pain, the patient is not able to sleep. Okay. Many things are the disturbed patient, the fear of the wound, fear of thinking how I will die. Yeah, fear of death. Okay, how I will die, whether I will bleed, whether I will have this problem, all saying. And maybe due to malodor itself, the patient may not be able to sleep also. Due to smell, the foul smell, you cannot go to sleep. So this all can happen. And also preventing infection and promoting wound healing. So let me say in the first slide itself, Akshata, you have written about delayed wound healing. Okay, I agree. But in a cancer wound, don't expect that the wound will heal. Here, our main aim is to reduce the problems in a wound. Not wound healing is not our focus.
Yes, ma'am.
Our focus is to have a good dressing we do, reduce the smell, prevent bleeding, prevent maggots, and pain. Okay. It's not about wound healing. Wound healing can be done in a diabetic patient or a pressure ulcer, other wounds. But of course, in these wounds, which is almost so develop, like a breast cancer developed wound, it's not going to heal, but we can prevent the problems. Okay, so like prevent
Okay.
infection. So we already spoke how to prevent infection. What all things we said about preventing infection?
Daily dressing,
Yeah, daily dressing. Then
maintaining
Right.
Aseptic technique.
yeah,
Maintaining good hygiene by the patient.
yeah, maintaining good hygiene, covering the wound
covering 24
regularly.
hours, and daily dressing you already said.
Daily dressing, yeah. Aseptic technique should be done good. Yeah. So, yeah, very right. And using antibiotic also for the patient, not systemic, at least for the local, we use antibiotic. Okay. So that is very important. Then one more thing is very important. Okay. That is aseptic technique we told for us. But explain to the family member, hand washing is very important. Ask them not to touch here and there. What dressings they are using, it should be sterilized. How to make saline. These things are very important to prevent infection again. Okay, and a follow-up of these things. So last question, of course, how can we control our blood sugar levels? That they have to better to see a medical specialist, physician. Okay, maybe that insulin what she's taking may be not enough. That is why can use metronidazole without doctor's order. Pooja, where are you working? Are you working in a palliative care or are you working in a corporate hospital or something? It is according. You can go and you can talk to your doctor, tell, because in palliative care, of course, we don't have any problem. We use it. But if you are working in a corporate hospital or any hospital, the protocol, I don't know what it will be. So if you think that this can be used, you can actually approach your doctors and talk to them about using this. Okay. So blood sugar levels, as I said, it's better to let them see a physician. It's not that patient is in palliative care or something. They can go for ahead. Maybe they are not giving it properly. Who knows, insulin, what you have written, the same dose they are not giving. There may be some problem. Otherwise, maybe since long they are taking the same dose. It can also be. Okay. So, anything else?
No, ma'am. I think almost all the point we have discussed.
Shiva, can I leave? There is a meeting for
Yeah,
me.
yes, you can.
I will call you afterwards. Okay.
Yeah, ma'am. Thank you. Thank you so
Thank you
much.
all. Thank you all, dear. Okay. Bye.
Okay.
Thank you,
So,
ma'am.
yeah, here we have to understand about one thing. While we doing the dressing, the doctors, the patients may be asking you like, my wound is healing well, isn't right? So these kind of questions sometimes they will ask. How will you respond? My wound is healing well, isn't it? These kind of questions they may ask you while doing the dressings. How will you respond? Anybody? Anybody? We need to answer it, right? If they ask something, we have to answer it, no?
To prevent infections.
Okay, so the question is, my wound is healing well, right? That is the question. How will you respond? We know this wound is not going to heal well. This is a non-healing ulcer, but still the patient is asking like, my wound is healing well, isn't it? We know, don't give false hope. How will you move forward?
I would say that due to the nature of your condition, this wound is not going to completely heal, but we are doing our best to prevent complication.
Okay.
And
Thank you, Dachin. So, any other answers? So as Dajan said, what we can do is we all know that don't give false hope. It will not heal, but don't give directly that answer to the patient. We have to understand their insight about the disease. What their insight. You have to listen. You have to give a empathetic expression towards the patient, and after dressings, then you at that time you have to tell them like we will talk later. After dressings, we will sit together and talk. And after dressings, you have to sit with the patient and ask them that what is your insight about this disease, what your expectation. So that kind of things you have to. After that, you will get an idea about their insight. Okay, then you can able to give a warning shot. It's like a breaking bad news. So you are going to tell about the bad news to the patient. So that will be affecting the patient emotionally and spiritually too. So we have to prepare the patient and family well, and then you have to convey the bad news. Like as you can use a spikes protocol. So that is very, very important. Don't give false hope to the patient. Okay, so you have to tell them gradually this wound is not going to heal well, but we are here to take care of your problems. We will try to control your problems, that symptoms. As much as possible, you have to give good symptom management so that you can able to make well, so feel well. So these kind of things you have to convey. Some positive things also you have to, because otherwise they will be thinking like, oh, no, nobody is there to take care of me. Well, so better to suicide. So these kind of things will be there. So better you have to convey this message to the patients like using spikes protocol. And what are the problems faced by this patient? That is also important. What are the physical problems? Physical problems we already discussed. What are the psychosocial issues here? So you have to think about the psychosocial issues here. So she is having two children, one boy and one girl. So what are the psychological problems here? Why she is not able to sleep properly? Disturbed sleep. Always she is thinking about her children. And the husband is only one breadwinner, but he is also she is not able to fulfill his wish, because she is a mother as well as she is a wife. She is not able to do the both role. So this will be affecting the patient emotionally and spiritually, because why God punished me like this? These kind of spiritual questions will be there. So what we can do is you have to sit with the patient individual assessment. So that is very, very important. You have to explore the patient concerns, emotions, so that they can able to ventilate their emotions, and if possible, you can manage through that. After when they express their emotions, definitely we can able to manage well. So at least sit near to her and listen her worries. That is very, very important. Always think about the total pain: physical, emotional, social, and spiritual. Sometimes the relatives maybe will not be able to visit because of the misconception. They will not they are not willing to see this kind of patients. So the social isolation will be there. Sometimes family isolation will be there. So these will be affecting the patient socially also. So if these kind of things there, definitely we can able to help them, like talk to the relatives, talk to the neighbors, and make them understand that this is not a communicable disease, like not spread to others, because this is a cancer. So how the cancer is spreading? These kind of things you have to tell them. Cancer is not spread. These kind of things you can tell them and convey them, so that we can able to reduce the misconception. So these kind of things you have to keep it in mind. So always you have to think about the total pain things. And also medication history. That is also very, very important. The patient is taking tramadol, so at the same thing, you have to take a proper pain assessment. If the patient is not getting adequate pain relief with these medications, you have to think about the next step. And also, you have to try to prevent the side effects also. Okay. So others points we already discussed. Anybody have any questions? Any comments or any last minute questions there? Please ask. So constipation things always try to manage with the non-pharmacological measures, and then you can think about the pharmacological management. Okay.
Okay. Thank you, Olga.
Okay. So if you don't have any questions, we can wind up. Okay, we can wind up. Thank you.
Thank you, ma'am.
Okay, though Stella ma'am is not there, I'm thanking her for the wonderful session. Thank you, Sheba ma'am, for your wonderful facilitation. Thank you, Akshada, for your presentation. And I thank all of you for your active listening. And I expect tomorrow more attendance I'm expecting because it's too low today. I'm expecting more people tomorrow. We'll see next day.
Thank you.
Thank you.
Okay, ma'am. See you.